Hi everyone, this is Neel Raithatha, consultant audiologist and director of Wax. Thank you for joining me in my latest video using the Waxscope. And here we have a patient who attended with a blocked right ear. And that visual you're seeing there is the patient's eardrum, and it's covered and smothered in mushy dead skin, which is possibly infected as well. So this patient usually sees ENT on I believe every 6 weeks. Now, I previously saw this patient. This patient's actually a hearing aid patient, or used to be a hearing aid patient of mine. We've referred them for bone-anchored hearing aids because they struggle and suffer from chronic otitis externa, outer ear infections, which prevents them from wearing their traditional air conduction hearing aid. And previously, I suspected this patient may have a canal cholesteatoma. So this patient underwent exploratory surgery. I don't really know the outcome of that. So the patient themselves are not sure the outcome. They were just told that they need to go every 6 weeks or so to get their ears cleaned. And because I referred the patient to ENT via their GP, we don't get any correspondence back from ENT or the GP. If the patient decided to go private and we made a private referral, then typically ENT would communicate with us. So it's a bit left in the lurch. But there, you can see this cavity I'm here looking at there is an erosion. It's a widening, and in the past I had really hardened keratin embedded. So I'm just cleaning this cavity. So this shouldn't be there. This is an expansion of the ear canal. And typically this is for one of two reasons. It could be what we call a condition benign osteonecrosis, or it could be a canal cholesteatoma. I'll explain the two. I suspect it's possibly more a benign osteonecrosis because there wasn't any ulceration today. Although there was a bit of discharge, there was a bit of granulation tissue, but the skin was intact. That doesn't mean it's not a canal cholesteatoma, but I just suspect it's a benign osteonecrosis. And so a benign osteonecrosis is when there's reduced blood flow to the ear, to the bone, the floor of the bone, typically the tympanic plate or the temporal bone, and with the lack of blood supply, the bone just undergoes a process called necrosis, so decaying, and then eventually the bone can undergo a process called sequestration, which is a separation of the bone, and essentially it creates a kind of a pothole, if you like, a widening, a basin, because the bone is no longer present, and the ear canal sinks in to the floor of the ear canal, and the skin that's lining the ear canal does also. And when you've got a benign osteonecrosis, you normally need regular cleaning. A canal cholesteatoma is when you have a dead skin cyst forming in the ear canal, and that dense skin cyst then begins to release what we call lysosomal proteolytic enzymes, which are digestive enzymes, and you then get bacterial involvement, which also themselves release proteolytic enzymes, and these enzymes start to basically chew up flesh, bone, anything in its path, and it's locally destructive. And so it's quite a serious condition because it can spread to the back of the ear, to the mastoid bone, to the floor of the ear canal. It can sometimes expand anteriorly towards the temporomandibular joint or the parotid gland. So it does need to be treated quite urgently by ENT, or at least assessed. So here it's just layers and layers of skin, and I suspect this patient has possibly got an underlying chronic otomycosis, a fungal infection. So fungal infections typically are chronic, and they cause itchiness, which this patient is experiencing. The patient didn't experience any pain, no otalgia. And it's interesting, I had another patient just come back to say thank you to the clinic. I think it was at the beginning of last week. So this other patient who I saw has themselves been suffering from chronic otitis externa, similar to this patient, and they've been prescribed antibiotics on multiple occasions, and I advise the patient that I suspect they've got a fungal infection. So when you've got a fungal infection, and that can develop secondary to treating a bacterial infection. So when you have a bacterial infection, if you have prolonged exposure to antibiotics, it not only inhibits and kills the bad bacteria, but also the good bacteria, because we have good bacteria that forms part of the skin flora in the ear canal. And in the absence of any bacteria, the natural fungus that we have in our ear, which again should normally be healthy, shouldn't be pathogenic, has no competition, so then it exponentially reproduces, it overgrows basically, it elicits an immune response from our immune system, and then you can get otomycosis, a fungal infection. So this patient I was referring to, I wrote to their GP and I just recommended they have a swab taken because I do suspect they had a fungal infection. And according to the patient, the doctor was quite damning of me. He says, well, what does he know? He's an audiologist. I know better, and it's a bacterial infection. But because the patient insisted, they eventually got a swab, and yes, you've guessed it, it came back as a fungal infection. So I think the GP was a bit embarrassed when the patient, when they contacted the patient, and the patient actually just came in to say thank you, because if it wasn't for the letter and their insistence that they get a swab, they were just being prescribed antibiotics, and being prescribed antibiotics for fungal infection is not only going to it's not going to help, because the antibiotics are not going to kill the fungus, but you can then develop immune response to, you can develop immunity to antibiotics. So there is a big thing at the moment, especially within ENT, of trying to minimize unnecessary antibiotic prescriptions, particularly for middle ear infections. So otitis media, quite often in primary care, otitis media, acute otitis media is over-diagnosed, and therefore a lot of patients are prescribed antibiotics. The number one cause for acute otitis media is actually, it's not a fungal, it's not a bacterial infection, it's a virus. So you can get bacterial otitis media, but most commonly it's viral. So now this case was really complex because there's no wax, it's just this infected damp skin that's smothered all over the patient's ear canal and eardrum, and this is the perfect case to really put the Waxscope to test. In fact, I've had many complex cases today where I decided to use the Waxscope, so do stay tuned for those. And I'm just using the fine end suction probe. One of the things I've noticed, so with the Waxscope we can't use the normal fine end in the UK. So with the fine end in the UK, it's an extension, and you attach it to the end of the Zollner suction probe, and that's because it has a little ridge where it connects to the Zollner suction probe. And with the Waxscope, you've got this slot, and when you sometimes enter the fine end that's attached to the Zollner, that ridge comes in contact with the edge of the slot, so you kind of jarred. So I now use suction control handles, so they're separate to the suction tip, and then you attach different size suction tips onto the end of the suction handle, so there's no ridge. And actually it's a much better system, and I wasn't aware they even existed, but they actually, other than the UK, it's the most common method of suction tips around the world. And I'm starting to manufacture these now, and we are due to be launching them in New Zealand very shortly. So if you are a clinical ear care specialist, so whether it's ENT, GP, nurse, audiologist in New Zealand, and you're interested not only in our right instrumentation, so the right angled curette, the straight double-ended curette and hook, the angled ear pick, and the full range of suction tips. Now, I've done the suction tips in two lengths because in the UK we generally use a specific angulation and length. In different parts of the world, again, there's different lengths of suction tips, and I actually see the benefits in both. For a normal Zollner, which is a 14 gauge, I normally use the UK version of the angulation and length, but when it comes to the fine end, I generally now use the longer one, I just feel like I got better control, and because obviously an 18 gauge fine end, the steel's a lot thinner, and with the longer one where the bend is more proximal, it's got more rigidity to it, so it's not kind of flopping in the ear if when you're going deep towards the eardrum. But yeah, if you are from New Zealand, we're just waiting for the paperwork to be authorised, so it should be launching very, very soon indeed. Please email info@clearwax.co.uk and I can forward on to you our distributor details in New Zealand. And once it's fully launched, I will advertise it on my channel and videos and social media. So there's a lot going behind the scenes, so I apologise of not being uploading many videos at all recently. There's a lot of things, not only New Zealand, there's other territories around the world now that we're working with distributors. There's a lot of audits going on. So yeah, hopefully in the next 2 to 3 weeks, things will be a bit quieter on my end. I say quieter, not quiet, because there's a lot of work involved now when you're manufacturing medical devices. So, but I will be uploading a lot more videos shortly. So I'm just going back into this cavity. It's on the posterior inferior canal wall. It's on the bony parts. I would say it's the pars media. The ear canal, you have it can separate it in thirds. So the outer third is the cartilaginous portion. We can call that the pars externa in terms of the location of the ear canal. The midsection is called the pars media, so that's the bony portion. And then you've got the inner third, which is the pars interna. So I'm just lifting some crusted skin. So these procedures are far more complex than when you've got wax, occluding wax, because you're working up against the canal wall continuously. We're on the cartilaginous portion, so I can put a bit of pressure here. So whenever you're working very close to the canal wall, you need a lot of precision, you need magnification, you need clarity. So I thought it's a perfect demonstration of what is possible with the Waxscope, because I don't think I'll be doing this with I would do it at an endoscope, of course, and the ENT microscope, but I wouldn't be doing it with any other visualization method. It's just too precise a procedure. So you just got some crusted skin here. I'm just going to peel this away. You can see that indentation, that erosion at the floor of the ear canal. So this patient is due to see ENT very shortly. The reason why they came to me today is, so they're normally seen on the National Health Service, because it's every 6 weeks they need to be seen. Of course, it can be very expensive for a patient to be seen privately. So the NHS now, he's now getting free treatment on the NHS on a regular basis, but the appointment got cancelled, and the patient could feel a lot of itchiness in their ear, so they decided to give me a call, and they are awaiting evaluation of a potential, what we call a BAHA, bone-anchored hearing aid. Most hearing aids, they amplify sounds through the ear canal. With someone with chronic ear infections like this, it keeps damaging the hearing aids. So you can get bone-anchored hearing aids, you can get implantable ones where a bone conductor, vibrator if you like, is attached to the mastoid bone under the skin, and on top of that you've got typically a magnet or titanium abutment, and attached to that is a processor which is with a microphone, and it vibrates the skull, and these vibrations are then transmitted to the cochlea, the organ of hearing. So there's no need to wear anything in the ear canal. Well, I hope you enjoyed that video, guys. I did speed the video up because I wanted to get it below 15 minutes so I can upload on Instagram and also LinkedIn. Take care, guys. Bye.